All right, welcome everybody. Thank you for attending this webinar. We're going to be talking today about the foundations of documentation and establishing the need for treatment. So joining me, my name is David Eckert from Coordinated Care Services. Joining me is Daniela Labate from NIAPRIS and Naomi Weinstein from the Institute for Community Living. So together we've created this presentation as part of our series, and this is intended to be, again, a presentation that talks about the foundations that are essential for clinical documentation. So let's talk about those involved in this presentation series for MCTAC. We have the McSilver Institute for Poverty, Policy, and Research. We also have CASA, the National Center for Addiction and Substance Abuse. Additionally, our partners here, CCSI, again, my name is Dave Eckert, I'm from CCSI, Danielle Labate from NIAPRIS, Naomi Weinstein from ICL, and we also have the NYU Ideas Center, who specialize in evidence-based practice work and really trying to promote the use of evidence-based practices across the state. Our agenda for today, we're going to, again, talk about the importance of documentation, why documentation in general is so vital to effective treatment. And we'll be covering those basics. What makes documentation effective? What are the elements that need to be included so that it gets the job done? We'll talk about the golden thread of documentation and explain how that continuity and consistency in documentation should be present in the clinical record from assessment through planning, through service delivery, right up until discharge. Vital to all of this is person-centered collaboration. Documentation is not just for clinicians. We're going to talk about how vital that is for our client population and for the people receiving services, that the documentation really reflect their needs and what we're doing to address those needs. And central to this, leading into our next presentation, which will be on treatment planning, we'll talk and have a particular focus related to assessments and diagnosis as foundational to beginning that golden thread, and again, central to effective documentation. So at its core, what are the basic elements of documentation? What are the questions it answers? Documentation is the written account that tells the story of how a person receiving treatment's needs were met by the service providers. It says who is receiving the services, who's delivering the services, what were the needs, what were the services provided, where are the services provided, when are the services provided, and the duration of those services, and importantly, why were the services provided, what are the needs being met. And very importantly, as we move into a world of value-based payment where outcomes are really stressed, we want documentation to show how the client benefited from the services provided. So an important point to remember, I think we've often, and we've all heard the saying, well, if it wasn't documented, it didn't happen. Which means that if it's not part of the clinical record, how do we go back and show that it was a service that was delivered, that it was a call that was made, that it was a conversation that happened, that it was anything related to client care? If it's not in the documentation, we have no way of supporting the fact that it ever happened. Well, we'll add a word to that if it isn't documented well, it didn't happen. Because though it may have been documented, if the documentation misses many of the key elements and those key questions we just covered weren't answered, then we can't know exactly what happened and how it benefited the client. So documentation is essential. It is the story of what we do to meet clients' needs. The purpose of documentation. So why are we documenting it well? Why is there such emphasis on documentation? We've heard people say, you know, I deliver effective services, I'm just not great at documentation. Well, they really go hand in hand, because quality services are reflected in quality documentation. And the purpose of that quality documentation shows the coordination of care. What is happening in this day and age of integrated care between the mental health needs, the substance use needs, the medical needs, the residential needs? How are all those needs being brought together, and how do we demonstrate in the documentation that care is being coordinated effectively? Again, all of those things should be in the client record. It also reflects shared decision-making. That is the process of working with clients in a person-centered way, and we'll talk more about that in this presentation, talking about what is important to them, what do they want to get from the service, and also what is important for them. We are the experts in the service we're delivering. We also want to guide them. And together, we come up with a plan, we assess for needs, come up with a plan, and deliver treatment that is a part of that shared decision-making process that shows that we're working together with the clients leading the way and us supporting them every step of the way to make effective decisions regarding their care. And first and foremost is risk management. We need to keep people safe. So risk management, obviously, essential to document well and to assess for risk, to address risk, and to show that risks have been successfully addressed. We also need it to get paid. The authorization and reauthorization of services depend on effective documentation. Again, as we're seeking payment for the services we're providing, the quality of our documentation will speak to the quality of services we're providing and whether or not they're working for the folks we're serving. There are also audits by licensing agencies, OASIS, OMH, et cetera. All agencies operate under these licensing certificates, and how do they review services? Well, they come in and they look at the clinical records. They may follow up and ask us to answer questions about the records, but the records need to speak for themselves in these audits, and the licensing agencies will depend on what they see to evaluate the services provided. We will also evaluate, again, the results of the services. Does the documentation show a progression toward recovery for whatever type of service is provided? And again, this presentation covers the essentials of documentation that will apply to all services: care coordination, residential, mental health, OASIS services, inpatient, outpatient. All of these basic tenets and elements of documentation apply across the board. And we also depend on effective documentation for our quality improvement efforts and our utilization review. So when we're looking at our services and we're doing that plan, do, check, act approach to see that services are approving, and utilization review to make sure that people are at the correct level of care and receiving services that address their needs, it all depends on effective documentation. So it's multifactorial, the need for effective documentation and clear documentation. The risks of inadequate documentation. Well, before we move on here, let's do a check of where we've started, and we have some preliminary questions before we get further into the material here. Let's take a pause and let's talk about where we're started. So if you could take a minute and look at these polling questions. We've got 3 of them for starters here. First, let's have you respond as to your role. Are you a provider, a supervisor, a provider and a supervisor, an executive of an agency, a consumer, or a member of a consumer group? Are you a peer, advocate, a mentor, or a family member, or in some other category of individuals who are stakeholders in receiving services? So take a second and let us know who's on the presentation. And the second thing we're going to be stressing is medical necessity and documentation. So tell us about your degree of understanding as to how much you are aware of the importance of medical necessity. So I have a good understanding of how to show medical necessity in documentation. Do you strongly disagree with that statement? Disagree? Are you neutral? Do you agree? Or do you strongly agree with that statement about your awareness of medical necessity in documentation? And the last preliminary question we have here is related to the golden thread of documentation. I have a good understanding of what is meant by the golden thread of documentation. Do you strongly disagree with that? Disagree? Are you neutral? Do you agree? Or do you strongly agree with that statement as to where you start before we delve further into this material regarding your understanding of the golden thread? So please take a second and review or answer those questions, and we'll be able to have that feedback from you to answer preliminarily. So looking at what we have here, we have a real mix across the board here of who's participating in the webinar here. The answers are coming in rapidly here. So it looks like a lot of providers, a strong representation of supervisors, a good amount of people that are both supervisors and provide direct care. We have executives present, family peer members, great to see that, and others as well. So in terms of your initial understanding, it looks like we have a decent basis of understanding related to documentation here, a lot of grouping around the middle of that question there. Hopefully, as we progress through these details here, we'll be able to move you to the other end of that spectrum and help with your understanding of medical necessity. And when it gets to the golden thread, looks like we will, it'll be important for us to cover that and hopefully move those who don't see themselves as understanding that well, who disagreed or strongly disagreed with that or are neutral. We really want to help your understanding of that. So thanks so much for taking a minute to answer those questions. Again, you'll see a couple of those related to medical necessity and the golden thread repeated at the end, and it is our aim here to really emphasize those elements and help with your understanding of that. Excellent. We really appreciate that. Okay. Thank you for that pause for preliminary questions. So let's get back to what are the risks of inadequate documentation here. So what if people feel like, you know, I provide great services, I'm just not an ace at documentation. It's not one of my strong points. Well, we live and work in a day and age of managed care who are overseeing the vast majority of Medicaid dollars that are spent, and that is the expectation, and appropriately so. We want to make sure we're investing wisely in across the board in the services we're providing. So the managed care companies may request additional information, delaying authorizations or reauthorizations. And if it's not in the documentation, it may result in a denial of needed services. Also, because everything goes back to the CMS regulations, the Center for Medicaid and Medicare Services, we have a real need to follow their regulations and provide documentation that reflects what they need to see as well, again, so that we're following Medicaid regulations and ensuring reimbursement for our services. So very important for payment as well. So documentation today needs to consider multiple masters. There are multiple needs we need to address that are covered when our documentation is effective. We need to consider, of course, managed care, as we just said. Also, our state licensing agencies, all of those O agencies we answer to, OASIS, OMH, OPWDD, et cetera. And we also have our internal agency requirements. What is it that's particular to our agency that we also may want to capture related to CQI and other efforts to make sure that we have the documentation to build the data to work off of. So hopefully these needs overlap. hopefully what the regulators want us to capture, what the payers want us to capture, and what our agencies want us to capture has a lot of the same elements in common. But this may not always be the case. So we do have to be aware of all of the needs and what is expected of us in terms of documentation. So we look at the formats and how we capture documentation. Each managed care company has its own rules for authorization and reauthorization process. And by the way, a little plug for MCTAC here. If you have questions about the managed care authorization and reauthorization, we have a wealth of information available to you. We'll show you our contact information at the end of the slide. And with any questions that come up in this presentation, please feel free to answer those questions. And we're happy to assist. So let's talk about that managed care authorization, reauthorization. We may get a phone call and get questions on the phone to take these questions and answer them related to specific client care, about the treatment that's being provided, about the assessed needs, about the treatment plan, how are we planning to meet those needs, and about the progress in treatment or other questions. So if we have solid, effective documentation that covers these necessary elements, it makes those conversations go so much easier. Everyone has the same end in mind, and that's to help people move toward recovery. And when we have solid documentation that reflects that, we can have an effective conversation about that. But to do this, we need providers to be skilled in written documentation, again, that reflects what they're really doing. In my travels and in my work, I've heard people say that it's an additional skill to the clinical skill is how to document it well. And I think that's very accurate. And I think some practice, guidance, and trainings like this are extremely effective so that the rules and expectations are as clear as they can be. And in my experience, people respond well when expectations are clear. So we want them to have that written documentation to know the expectations and to deliver on those. We also want to translate that written documentation into the oral presentation for phone conversations. Other than just reading off the page, how do we translate the work we're doing in assessing, treating, and the progress the clients make? How do we translate to an effective conversation that supports the investment of the Medicaid managed care companies in these individuals' treatment? So, qualities of good documentation. I'm going to turn this over now to Daniela Labate, and she's going to talk more about the qualities of good documentation.
Thanks, Dave. So the first thing we wanted to stress with good documentation is that the documentation is easy to read. You want to be able to quickly see who the person's name who's receiving the services, as well as the person's name who's providing the services, and that their signatures are there and easy to find. Grammar and spelling is super important. Make sure you spell check, make sure that your writing is clear and that you're not using any unfamiliar words or acronyms or abbreviations. And if you are, to spell them out the first time and put them in parentheses and then use the acronyms going forward. We want to make sure that we're always using quotation marks when we're quoting people and that we're not using any slang or curse words in our documentation, unless you're quoting the person, of course. And that if you're not using an electronic health record and handwriting your notes, that they are legible and that they're written in a timely manner, that they're dated and written when they occur. We can move to the next slide, please.
Thank you.
Okay. We want to make sure that documentation is meaningful and not overwhelming. So more is not always better. We want to think about quality versus quantity. So we want to be able to write notes and document in a way that you're reflecting the facts of what happened in that session and connecting them to the treatment plan. Not necessarily telling a story, but writing and documenting about the services that you've delivered and why those services are important for that person's treatment. We want to be able to describe functioning and functional impairment going beyond a diagnosis. So how are those symptoms or how is that diagnosis impacting that person's life? And keeping all of this in mind is that notes can be shared and or subpoenaed. So, you know, clients do have the right to request their records, and thinking about whether or not that person would be upset if he or she read their documentation. So really writing things in a very person-centered way and in a way that matches what their goals are, what their intention of treatment is, and while also documenting medical necessity. So we're going to take a look at a couple of notes now. And this is an example of an ACT visit note. So you can take a minute to read through this. I'm not going to read the whole thing off the screen. But I do want you to see from this is that it's very lengthy. It's written almost as if it's telling a story. There's sort of a play-by-play about what happened in this interaction, but there's really no information documented about what services were provided. We do know that this person, SR, just got out of the hospital and was discharged from the hospital, but we don't know of any interventions that were offered at this visit. So now we're going to take a look at at this note, but in a corrected version of it. So we do see that it's much more succinct. It's, you know, documenting a discussion about follow-up, plans to move, follow-up with other providers, so that there's some continuity of care that's being documented, but there's still something missing. So think about what's missing as we move forward and talk a little bit about continuity of care, and then we'll show you the more corrected note. Okay, so documentation needs to show continuity of care. We want to show progress over time or lack of progress over time if there's lack of progress, and whatever interventions we're using to address that progress or lack of progress. We need to demonstrate how a person's needs are addressed, you know, whether it's community support or mental health, chemical dependency, medical, residential, and we really want to think about the services that you're providing as a part of a bigger picture. So whether that person has a care coordinator or you know, their nurse practitioner or psychiatrist, really thinking about the services you're providing, how that fits into the bigger picture of what they're doing with all of the other service providers that they're working with. Okay, so let's break down medical necessity a little bit. There are some basic tenets to medical necessity. Services need to be provided by an appropriately qualified practitioner. We do know that for each service, for each HCBS service, for example, there are different qualifications for each service that's being provided, that they should be clinically appropriate. They can't be too strengths-based. They should focus on symptoms and the need for care. They should be delivered at an appropriate intensity and duration. So services should not be, you know, provided on a forever basis, right? We want to make sure that a person is receiving the amount of services that is correct for that person and at the intensity that's correct for them. They should be prescribed in an individual treatment plan, and these interventions or services should be designed to improve functioning and symptoms or prevent worsening of symptoms. And they should be based off of a diagnosis and an assessed need. So when someone comes in for treatment, you're doing assessments with them. Out of those assessments come formulations and a diagnosis. And then based on that diagnosis, you're going to build a treatment plan with them, and that treatment plan will have interventions on them. Okay, so here are some tips for demonstrating medical necessity. So we only want to document the services that target the symptoms or behaviors that are identified in that assessment. Excuse me, if a person is stable, there's really no need for services, right? So medical necessity should be documented in each and every time and in each and every note for each service that you're providing. And for people with mandated services, there may not necessarily be a medical necessity, quote unquote, but the goal should reflect the reason for that mandate. And services to collaterals should still, services to collaterals must still be for the direct benefit of the person, and they should be included on that person's treatment plan. And then that person should have capacity to benefit from those services. So let's go back to that ACT note example. So here we have the example we just showed you, but we see what's missing, right? There's no statement of the progress or continued symptoms or lack of symptoms or improvement of symptoms, and there's nothing noting that what interventions were provided. So here's the improved correction now. So we see that there's spelling and grammar corrections were made, that there's continued symptoms and recent progress in that we're talking about his behaviors upon discharge from the hospital. The intervention of risk assessment was documented, that there are direct quotes from the person receiving the service talking about his move or her move to Boston, and that we're showing a continuum of care and that there are other providers involved in this person's life, and we're trying to help that person keep that connection with the other providers. And just a rule of thumb is that anyone should be able to read a note and have a clear understanding of why this person is in treatment and what the services they're receiving are. So this note gives us an idea of why we're providing this service.
And one thing I would add, Daniela, too, is to ask themselves, is this a service that should be paid for? Did something happen here that is worth Medicaid investing their dollars in?
That's a really good point. Thanks, Steve. And which leads us to this slide, actually. Care is justified if you can show a reduction in care that will lead to, if you can show a reduction in care will lead to an increase of symptoms. So why is this person receiving treatment? And why is this treatment or this service important for this person? So we're going to jump into the idea of the golden thread right now. So this is basically an idea about continuity in documentation, and there are three components that we want to talk about. So it's the assessment data, and out of that assessment data comes the diagnosis, the person's strengths, talking about their goals are identified, their needs are identified in that assessment or as a result of the assessment. And then that leads us to the formulation of a service plan, which has clearly defined goals and objectives and interventions. And we want to make sure that those objectives relate to that person's goal and that the interventions are related to the objectives. And then the interventions or services are documented in the progress notes, because we're looking at that progress note or we're meeting with that person and documenting that progress much more often than we're revising a service plan, for example, in some programs. So we want to make sure that we're always touching on what those objectives are, what the services or those interventions are, and if they're working. And if they're not working, then we need to think about that objective and that service plan and do some revising. Okay, so documentation must reflect the golden thread. Interventions should all reflect service plan, and the service plan should reflect the assessments and the client's goals and objectives. And the objectives have to be relevant to that person's needs, right? That's why they're in treatment, and that's what keeps us connected to medical necessity. And when we're doing documentation, we always want to think about being person-centered, that the individual receiving service is really driving their treatment. They're the expert in their life. You're helping them to identify their strengths and their interests and their preferences, their treatment preferences, for example, what their hopes and dreams are and what their needs are so that they can reach those hopes and dreams. But in doing so, we need to be mindful of people's cultural and linguistics, cultural backgrounds and linguistics. And we need to ensure that we're involving significant others or key collaterals, whether that's something that the person wants, or if they're a mandated person, they may not necessarily want a collateral involved, but we do need to include them, and that those folks are listed in the person's treatment plan as well. And person-centered practice also provides a systematic way to align what we do with what the person's needs and wants are. So we have some do's and don'ts for you on person-centered practice. We do want to let the person lead the process. We want them to be in the driver's seat. We want them to be engaged in treatment and to be working on the goals and the objectives that they've helped formulate with you. And we don't want to forget to include the other folks that may or may be involved, whether the collaterals. And supervisors should understand person-centered practice just as much as the person providing the treatment, because they need to reinforce these expectations as part of all of the delivery of the services. and we have one more slide on this section. So documentation and person-centered care, it's important to use quotes just to sort of sum things up. We want to use quotes whenever possible. It's reflective of the person's input into their treatment and the services that you're providing and that they're involved in. We want to define what's important for that person and to define the desired changes in terms of specific observable behaviors. And documentation is important for defining objectives, right? So that person needs to achieve what the person needs to achieve to be a valued community member, addressing their issues of health or safety, and addressing their willingness and motivation to invest in recovery. So when you're doing person-centered practice and you're providing person-centered services to someone, they're really going to be in the driver's seat. They're going to take ownership of their treatment, and you need to just be able to document all of those services accordingly so that they match with the objectives that you've agreed upon in their treatment. Okay, so Dave, I think I'm turning it back over to you now, right?
Yes, thank you very much. I appreciate it. So let's talk about collaborative documentation. Building on person-centered documentation and that shared decision-making process, considering what's important to the person, what do they say they want from treatment, and what's important for them, what we think, what we want to make sure we deliver, the way we do that is collaboratively. So this becomes clear evidence of a person-centered approach. Collaborative documentation means completing the assessment, the treatment planning, the pending notes, everything, that the person is aware of their treatment record, involved in their treatment record, and it's not just something that hangs out there beyond their reach or beyond their awareness. It's their record, they have every right, and they really should, from a standpoint of their own health literacy and knowledge of their own treatment, be aware of their treatment record and be involved in it. Concurrent documentation, actually doing the notes in session with them, is one type of collaborative documentation. They're not necessarily the same thing. We can be collaborative without literally typing with people in the room. But it is important, and it's often a very beneficial approach as well, to complete notes, to complete assessments, planning, and notes with the person directly. And a very time-effective approach, but again, it gets that person directly involved in their treatment by being very transparent about their clinical record and what's in there. Again, it's their treatment. They should know what's in their assessment. So to help with this and to be fluid with collaborating it with documentation, we want to know what's in our assessments. We don't want to have some scripted read of questions that have people feeling that they're really being grilled upon their entry into care. We want to do the assessment more as a conversation about what they need. In a trauma-informed world, we want to have the central theme being, what happened to you? Not what's wrong with you. What happened to you, and what are the needs that come out with that? So our comfort level and our familiarity with these assessments is very, very important so that it can be conversational. And that leads into the treatment planning. Again, we see the golden thread here. Assessment leads to identified needs, and it leads to treatment planning about let's talk about in a shared decision-making way what we're going to do about those needs. It should be collaborative. If it's not collaborative, then there's a risk for non-adherence. If it doesn't address what they really want to get from treatment, then it's a real potential to minimize their involvement and their investment in that treatment. And by the way, the research shows that collaborative documentation improves outcomes and reduces lengths of stay because of that investment in treatment. Progress notes as well. We always want to be aware of what's happening and how does the client think they're doing. Often, and having reviewed literally thousands of records in my role as a consultant for CCSI, we often see that the clinician will express how they think the client is doing, but more importantly, how does the client think they're doing with treatment? and using the final minutes of a session to wrap up and to summarize together in a collaborative way about what's happening in treatment, what are the interventions, and how it's working can be an extremely effective way to promote progress and keep clients invested in that progress. An important note here, we have the NISCRI 3 form set, a very impressive form set that's been developed through multiple stakeholders that currently focuses on OMH and OASIS regulations, and it covers assessment templates, treatment planning, progress notes, different kinds of assessments. I encourage you to Google NISCRI 3 if you're not already familiar with it. It's an excellent standardized form set. However, when we use that, it also comes in the form of drop-down boxes. And we don't want to be overly reliant on these drop-down boxes because we might lose the narrative, the importance of individuation, the open-ended questions that lead to those quotes that get to what does the client need and what are they doing about those needs, how do they think we're doing at helping them meet those needs. These are very essential. So when using these standardized forms, please don't be overly dependent on the drop-down boxes which offer standardized information. Also, please take full advantage of the narrative fields so you can provide those quotes and tell the full story. So, documentation and assessments. Going back to that golden thread and back to where we start, the background information in assessments needs to contain the referral source. Was the person self-referred, referred from probation, parole, were they mandated, was it a family suggestion, did they come from another level of care, etc. What's the reason for the referral and who sent them there? Then, of course, we need to capture the presenting problem. In a trauma-informed world, we're capturing what happened to you, what led to the trauma, and not asking what's wrong with you, but what's the presenting problem in terms of relevant safety and risk concerns. Again, you'll hear the importance of the use of quotes. We really want to capture their voice, what they want to get from care. And then in our words, for the important for part of that person-centered equation, we will describe why the person needs services and what we can do to help them at that level of care. Or if a different level of care is indicated, we also want to make sure we're presenting that and capturing that in an assessment. In the client history, this is another place where more is not always better. For the note snippet that Daniela reviewed, notice how the more succinct note was a higher quality and contained all the elements. So we want to capture the family history, medical history, behavioral health, education, work, social, trauma, etc., but as it's relevant to the treatment plan, as it's relevant to what the person needs and wants from treatment and how it will relate to our plan as to what we're going to do about it. You don't have to capture everything if it's not related to what the service is directly going to be implementing. So we want to describe what we need to know to best address those needs and capture all of that information. Documentation and assessments, the analysis and formulation. Now this is the end of the assessment where we have a summary paragraph or statements that talk about the symptoms and functional impairments. You'll see the standards of medical necessity come out in these questions. We, of course, will know what the diagnosis is, but what are the symptoms that support that diagnosis, and what are the functional impairments that come out of that? What's getting in their way because they have these symptoms? What does the person need from us in the services that we provide? How will these services improve their functioning? And is this the correct level of care? What is the correct level of care? Hopefully they've come to the right place and we can meet their needs, but if not, we want to capture that in the analysis and formulation that is the springboard for treatment planning, which, by the way, will be our next webinar. So, diagnosis and documentation. Diagnosis is important. It is the cornerstone of medical necessity, but in and of itself, it doesn't tell the full story. since many individuals can have the same diagnosis, but in varying forms, varying degrees, and a whole lot of individualized information needs to support this. So how is the symptoms of the diagnosis impacting the person's life? Again, that's going to vary based on the person. How will treatment interventions improve functioning? Of course, we don't have boilerplate interventions. We individualize our interventions to improve functioning. And of course, always our first rule of thumb is to keep people safe and to address risk and to include that in the assessment, including any psychosis, issues related to thought disorder, cognitive deficits, etc. We want to make sure we're capturing that information to capture the individual's ability to keep themselves and others safe. So here's an example, schizoaffective disorder. That in and of itself is important to have the cornerstone diagnosis, but let's look at specifics that can support that would tell a more thorough story here. So the symptoms for this individual include, and these are actual examples by the way, auditory and visual hallucinations and deep depressions. Notice the use of the quote there. So we would know that the client said that. They experience deep depressions that last up to 4 months, up to twice a year. And the client says this has been the pattern for the last 5 years. So we have the current symptom duration of 5 years and the intensity self-described as deep. And the client explains that hallucinations make it difficult for them to focus, of course, or to form close relationships with others, which makes it hard to finish school and get a job. So what an excellent way to support the diagnosis. We see the individual's goals can come out of this, to finish school and get a job, but we also note, again, the symptom intensity and duration is captured in addition to the diagnosis. So the standard components of initial authorization, we want to know who is the person seeking services, what is the relevant history, and the key word there is relevant. What are they seeking help for? We're addressing safety concerns. We're talking about the symptoms and the barriers related to those symptoms, and what do they need to have changed to successfully overcome these barriers. Hopefully it's offered at your agency. If not, you're referring to a program or agency that will be better suited to address these needs. For example, if a higher level of care is indicated, or if they're stable, maybe some community supports are indicated. And why would these specific services be most helpful? We want to answer these questions. And we provided you some examples by diagnosis. I won't read these in great detail, but everyone on this webinar will have these slides, and you can see the difference related to the diagnosis here. We've offered actual examples here. So, for example, this is a 52-year-old Hispanic female, symptomatic for 2 months with a family history of depression. We've captured a quote about what she's seeking help for, what happened to her, feeling sad most of the time, not enjoying anything, symptoms that relate to that diagnosis of depression, very common to see trouble sleeping with appetite disturbance, etc., interfering with relationships, missed work, etc., and what can we do to address that? Supportive care, cognitive behavioral therapy, and notice the quote of a broad global goal of clients saying, I want to get my life back again, which really captures, that's what they, when we return to that conversation about how do you feel we're doing at helping you get your life back again. PTSD, another example here, an actual example of an 18-year-old African-American of Caribbean descent, symptomatic for 4 months after a car accident. So the what happened to you question is answered here. Nightmares, flashbacks, etc. We have those avoidant behaviors we so often see with trauma, and with the intrusive flashbacks, etc. Fear, anxiety, CBT again could be trauma-informed CBT in particular could be a very effective approach. And with trauma-focused CBT, hopefully we'll have the individual graduating with their class Another example to review for you briefly, and again, you'll have these heroin dependence. Why is the person seeking treatment? Unsuccessful attempts at outpatient treatment. What are they seeking help for? Capturing quotes, etc. We're using the locator 3, of course, to determine level of care in the OASIS world. A great example of a level of care and intensity assessment tool that was developed by providers and managed care organizations, a great example of our current partnerships in our system to determine that intensity of the services we want to provide. And again, we've captured a quote. I'm ready to do whatever they tell me to do to get clean. So other examples here. So as we move forward, get my slide to advance here. So what can you do? As supervisors and direct care providers, we really want to review client records together. When we're in supervision, we want that to be just more than a conversation about, in general, how things are going. It really should be informed by a review of a sample of client records and documentation. Any clinician working in today's day and age needs to meet productivity standards, do effective documentation, show clinical outcomes, etc. And across the whole spectrum of care, these are challenging jobs, but it's very possible to complete all facets of the job. And the reason for these webinars is to provide you support in doing so. So supervisors and direct care providers should actually look at records and supervision to assess for the quality of the documentation and reflecting the quality of the service provided, all toward ultimately benefiting the client and their measurable progress toward recovery. So, references here. We have a multitude of excellent references for you. A lot of what we've shared related to treatment planning relates to the Adams and Greeter series, Treatment Planning for Person-Centered Care. They've written an excellent text there, and the second edition is out there in 2014. I highly recommend that book for those. You can use it as a reference ongoing in care. They give great examples. I find that it's a great text for guiding people, whether you're new or whether you're experienced. It really provides a lot of excellent guidance. Other references continued from journal articles we've reviewed, etc. So please note those references. If you have any questions about those, we're happy to help. And so questions in general, we have a few minutes left. We're happy to field questions. We've thrown a lot of information at you regarding effective documentation, medical necessity, the golden thread with specific examples. So let's read some of those questions. Where can you put the additional information in notes but not included in documentation? Where is an appropriate place to keep these kinds of notes and information for self? That's a good question. So if you're taking notes in session that are not part of the formal record, you typically do not include those in the formal record, and those are also things that can't be subpoenaed. Those are your notes to yourself. I think a common practice in my experience is people keep separate folders for their clients, and they keep them in a locked file cabinet. Always be HIPAA compliant with those notes as well. Be careful of PHI on those notes. Again, since these are notes to yourself, maybe you have a first name and a last initial, and you have notes to yourself. One very common practice to help people keep track of individuals' goals, objectives, and interventions is that people keep index cards that help them always be able to quickly refer back to people's treatment plans. So, is it acceptable to use the first person I think where was that question? I think it was backed up a little. Is the corrected note versus the caseworker. In general, as long as we know who's written the note, you definitely can use that. We just want to be very clear about that. You don't necessarily have to refer to yourself in the third person, but it just has to be clear who's writing the note and whose voice is speaking at that time. Spelling and grammar, yes, we serve non-English speaking population and try to have culturally congruent therapists, many also non-English primary speakers. How to manage. You know, I think that's a supervisory thing. We want to make sure the notes are clear to those that have English as a primary language, so assisting that person in having language that's clear and consistent and concise, I think would be very helpful, and that it would be a supervisory emphasis. A good way for documenting willingness, motivation, most of the person may not occur under pressure to attend, but they're not really motivated, happens when CPS tells a person come. In this example, there's no legal mandate, but they feel under pressure to come, so they go through the motions. I see a statement there, but not necessarily a question. And through motivational interviewing techniques, hopefully we get at why they want to come. Even if their motivation is to satisfy probation or parole or DSS, that is motivation in and of itself, and that's perfectly acceptable. And I think their motivation can come out of it through our person-centered and trauma-informed engagement strategies. They're there, they're in front of you, there's something they can gain from treatment that's important. Other questions here. Okay, yeah, some question number in line number 13 here, HCBS providers. Yeah, again, we've developed a presentation here that goes across the spectrum of care. Obviously, the diagnosis will get to the home and community-based service providers. They will not have to come up with a diagnosis, et cetera. However, the importance of everyone working in the field of understanding the golden thread and how the home and community-based services that you're providing address those diagnoses and address those specific needs is very important. So though you won't be diagnosing specifically, how the services you offer address those symptoms and barriers is a vital part of home and community-based services, and having that understanding is hugely important and helpful as well. Okay, other questions here? Can you please clarify who you are recommending be using the assessment and documentation? That is a good question. Again, we've developed a presentation that's meant to apply for essentials of documentation across the service delivery spectrum. It's important to have that foundational understanding and take from it the components that apply to your specific documentation needs. And if you're already given a diagnosis, symptoms, et cetera, and don't do that piece of it, well then certainly picking up on how your services address those needs is important. Do you have resources for writing notes for play therapy sessions with young children? That's a great question. I'm not sure if that's one of the examples in the most current Adams and Greeter text, but if you send us an email with that question, we'll send you a resource. Other questions we have here. Our clinic has patients who have been in treatment for a long time and have been stable. They would not be stable, they did not take the medication, have support, et cetera. How would you document need for continuation of care? That's an excellent question there. Remember, medical necessity documents clear progress. It also documents that services are important to keep people stable at their current level of care. So, in cases like that, where we're talking about people that have a history where they've used more acute services, and typically this, what we call the maintenance population, has used more acute services, whether it be emergency departments or have needed inpatient stays, I would make sure that I'm referencing that you're assessing for risk and that you're addressing those risks in an ongoing way and that the services you're providing are maintaining that stability. So though you're not, they may be stable and maintaining that stability is the focus of treatment, you want to notice, you want to make sure you're noting times when more intensive services were required and that you're assessing for the risk of them needing those more intensive services and addressing that appropriately in treatment. That's the cornerstone of medical necessity for those that are being maintained. Okay. Any other questions here? What does it mean when you say not too strengths-based? That's a good question. What we want to avoid is that there's been such a focus on strengths, which everyone has and need to be documented, but that they're absent of what is the diagnosis, symptoms, and the functional deficits. Sometimes notes are so strength-based that we've left out why the person needs treatment in the first place. So that's when it can be too strength-based if you fail to account for what are the needs and what will treatment do to address those needs. And I think that's all our questions. We have our remaining, those are all the questions you sent in. We have our final polling questions here. So if you could please take a minute and look at our final polling questions here related to medical necessity and the golden thread. We're really appreciating your feedback here. And I can't emphasize enough, you have our contact information. You'll be receiving the slides. We are very happy to answer questions that come up after this and to address any needs that you have in an ongoing way. We want to make sure our resources are available to you and you see us as a support in an ongoing way here. Please tune in to our next webinar, which will focus on treatment planning. So we're going to pick up from where we left off here in terms of medical necessity and the golden thread and get very specifically into the details of treatment planning, goals, what are objectives, how do we define those, what are interventions, etc. We really want to make sure that we're giving you the information that we need to treatment plan most effectively. Thank you so much for your participation. Again, please answer our final polling questions and send us any other questions you have. On behalf of our group here, thank you for attending.